Psychosocial Impact and Treatment of Celiac Disease, presented by Dr. Kimberly Burkhart and Dr. Monique Germone. We have no conflicts of interest to report. The learning objectives for this module include the following. The learner will be able to identify how symptoms, diagnosis, and adherence impact the individual, microsystem, and mesosystem, identify the impact of social determinants of health on social functioning and adherence, how to consider the impact of developmental stage when helping individuals with celiac disease and their families, describe the intersection of an individual's behavioral, psychosocial health and development and their impact on that individual's adherence to the gluten-free diet, assess and address medical trauma to decrease the psychosocial impact of the acute or diagnostic phase, and to describe the various therapeutic approaches to providing behavioral, psychosocial health care to individuals with celiac disease and their families. We will first address the impact celiac disease and a gluten-free diet has on the individual, one's interactions, and the bidirectional relationship between the impacted individual and the environment in which one lives. The psychological impact of pre-diagnosis, diagnosis, and adherence to a gluten-free diet can contribute to a wide array of internalizing symptoms and negative feelings, such as sadness, anxiety, guilt, anger, confusion, and isolation. These feelings are often associated with automatic thoughts. For example, there can be sadness as a result of thinking that one is different than family and friends and no longer able to eat preferred food. It is not uncommon that anxiety is experienced related to diet adherence and making safe choices. This anxiety can even result in hypervigilance around eating safe food. Alternatively, it should be noted that some individuals experience positive feelings associated with improvements in physical health as a result of adhering to a gluten-free diet. There is evidence to suggest that feelings do change over time, with initial diagnosis and adherence being associated with feelings such as sadness, jealousy, and annoyance, which then evolves into acceptance and establishing a new norm. It's important to consider the relationship between celiac disease and the environment. We've already identified the psychological impact of celiac disease and a gluten-free diet on an individual level, but now need to consider behavioral changes at the individual level in terms of interactions with others and the environments in which one lives. One way to conceptualize the impact is through the lens of Bronfenbrenner's ecological systems theory. This theory suggests that the environment in which one lives impacts all facets of life. In other words, if an aspect of the environment changes, this impacts the individual, and similarly, if the individual changes, this impacts the environment and the systems in which one operates or functions. Family, peers, school, and the neighborhood in which one lives can have the greatest impact on the individual, and vice versa. There can be a significant impact on the affected individual's physical and behavioral functioning. Prior to diagnosis, and if there is failure to adhere to a gluten-free diet once diagnosed, short-term physical effects can include gastrointestinal upset, migraines, and body pain, with long-term effects possibly including infertility, intestinal cancers, and osteoporosis. Due to these effects, there can be anxiety associated with accidental ingestion and cross-contamination. Findings suggest that those who are extremely vigilant tend to report a lower quality of life. The individual with celiac disease must take on many new challenges, such as learning to shop and to cook gluten-free. There needs to be acceptance of limited choices in certain settings, such as restaurants or the school cafeteria. When newly diagnosed, there may be avoidance of particular situations, such as birthday parties or other social gatherings. Self-regulation, an internal locus of control, is viewed as a protective factor. The individual who engages in self-monitoring has identified workarounds to prevent avoiding certain situations and settings, has developed brief educational scripts to be provided to peers, and has prepared answers to questions about dietary restrictions and adherence. It is important that clinicians promote both dietary adherence and social and emotional well-being. Physical effects associated with celiac disease, such as short stature, chronic fatigue, abdominal pain, loose stool, and/or headaches, can result in activity restrictions and impact day-to-day functioning. It is not uncommon that caregivers report guilt about their child being misdiagnosed or diagnosed after years of gastrointestinal complaints. Caregivers may also experience guilt related to accidental ingestion or cross-contamination. The majority of social activities are centered around food. The diagnosis of celiac disease affects eating practices at home in terms of purchasing gluten-free foods, meal preparation, and determining who in the home and when will others eat gluten-free. Families must also make careful considerations when eating at restaurants and make plans for traveling. School-related and extracurricular activities that might require making accommodations, including sporting events in which there are group snacks, eating in the cafeteria, participating in cooking classes, and attending summer camp. Those with celiac disease may feel that their interpersonal interactions and relationships are negatively impacted. Children and adolescents may report feeling peer pressure to eat what their friends are eating. They may also report feeling excluded because they may not be able to take part in specific food-related activities. Emotional support and stronger organizational skills are associated with improved social emotional outcomes and improved adherence. Findings suggest that the better the child or individual feels with his or her health condition, the greater their participation in social activities. Social determinants of health should be assessed at the time of diagnosis. Social determinants of health are defined as economic and social conditions that can affect disease presentation and management. Those in a lower socioeconomic status may lack access to follow-up care, may live in food deserts in which fast food is easier to obtain than gluten-free items, and may be on a strict budget in which obtaining gluten-free items is more financially impactful. Studies find that those with celiac disease declaring worse economic status have lower scores in social and emotional functioning. It should be noted that it is highly imperative that the caregiver of a child who has celiac disease must fully understand the diagnosis, food restrictions, and necessary meal preparation to avoid cross-contamination. When considering stress as an important factor related to coping style and adaptation, research suggests that a secondary coping style, in which children make efforts to adapt to the source of stress, may it be procedures, adherence to a gluten-free diet, or uncertainty related to management, leads to better adjustment. This looks different based on the individual stage of development.
As the previous discussions have highlighted, the impact of celiac disease and the gluten-free diet should not be overlooked and should be considered when working with clients in both a medical and a mental health setting. We will now review how to conceptualize cases from a developmental context. In conceptualizing clinical cases, it can be helpful to consider the impact of a medical condition. When considering the impact of a medical condition has on an individual, the intersection of the person's development should be taken into consideration. One of the most widely used theoretical frameworks on development is Erik Erikson's stages of psychosocial development. As you can see, development is on a continuum from infancy through 65 years and beyond. Considering a patient's development can be helpful in understanding the lens through which the patient is looking through when coping with a chronic medical condition. We'll highlight the main stages of development and the interactions with celiac disease in the next few slides. In Erikson's developmental theory, infancy is the first stage where the child is learning if caregivers will respond to their needs. It is important to note that while no one is born with celiac disease, children can develop celiac disease once starting solid foods. In the early childhood stage, ages 2 to 3 years old, children develop a sense of independence and control over physical skills. Since these stages require significant oversight from caregivers and minimal input from children, if a young child is seen in a medical clinic and/or an outpatient mental health setting, caregivers may need support in understanding how to create a gluten-free space for their child across daycare and home settings. Involving the medical team in this will be important to ensure that caregivers feel confident in creating a safe space. In the preschool stage, children begin asserting control and power over their environment. This often plays out with meal times and should be asked about of caregivers so that providers can assist caregivers in designing meal times that support their child's development while avoiding power struggles that could lead to eating gluten. When presenting for a medical or mental health visit, providers should be mindful of potential co-occurring anxiety and behavioral problems. Referrals for intensive supports for these concerns could be warranted. During the school age stage, children learn to cope with new social and academic demands. Schoolwork begins to get harder and children begin to play out new social dynamics. This is a point when children really begin to exert more control over their diet and begin to attend more social functions where food is served. Providers can assist families and children in the school age stage by screening for a child's understanding of the gluten-free diet and label reading, asking about the social and academic aspects of the child's life, encourage the child to continue to develop their understanding of celiac disease and gluten-free diet management, and determine ways to help the child and family plan ahead and problem solve in various settings. Adolescence is when caregiver involvement tends to lessen and the patient begins to take more responsibility for knowing about their celiac disease and management of the gluten-free diet. During this stage, teens need to develop a sense of self and personal identity. For instance, are they celiac disease or a person with celiac disease? This could be one of the toughest stages as the importance of social interactions are emerging and can influence choices regarding the gluten-free diet that may not have been difficult in previous stages. For example, their friends may want to eat at a restaurant, but that restaurant does not serve gluten-free options. What does a teenager do? Also, if a patient is diagnosed with celiac disease at this stage, it may be difficult to integrate this diagnosis into their identity after it has begun to form. This can make it difficult to adhere to the new diet. This is also a time of transition into high school, adulthood, and living away from home. Providers can encourage caregivers to move to a more supportive role at this point, rather than making all diet management decisions for the teen. Helpful tips for caregivers can include offering support to their teens by reducing their input around making mealtime decisions, supporting their child in knowing how to meal plan and prepare gluten-free foods, continuing to provide gluten-free foods that the teen enjoys, and providing their teen with opportunities to attend events that will offer gluten-free or no food options. For example, offering to drive the teen and their friends to a gluten-free restaurant that may be farther than the teens can walk to. During young adulthood, young adults separate from caregivers and form intimate, loving relationships with other people. The transition to living outside of the home can be difficult in navigating shared living situations, living in new places, etc., and trying to adhere to the gluten-free diet. At this stage, the patient is also navigating their own healthcare by figuring out their medical insurance, finding their own PCP, scheduling their own appointments, etc. Providers can assist with helping the patient transition their care from pediatric to adult providers by helping to locate providers and knowing what to look for in a provider. This stage also continues to be primarily socially focused. Many social interactions include food and can be difficult to navigate. For example, how do you tell a boss you cannot eat lunch with the team because the restaurant does not offer gluten-free options? How do you ask your date to brush their teeth before the first kiss? How do you explain celiac disease and the gluten-free diet to your in-laws? Providers can assist patients in this stage by reviewing common social situations and helping to identify problems that may arise and associated solutions to help prepare the patient for these scenarios. In middle adulthood, adults create or nurture things that will outlast them, often by having children or creating a positive change that benefits other people. Providers should be mindful that, for those that choose to have families, having children can be challenging for a patient with celiac disease. This is because their children should eat gluten, unless they themselves have celiac disease, and this can reintroduce gluten into the patient's previously gluten-free space. The patient may have to adjust their relationship with gluten as they may no longer be able to avoid it. In some cases, fertility can be a result of damage caused by celiac disease, and the patient may feel sadness, grief, loss, anger as a reaction to this. Providers can help screen for these concerns and make referrals for additional supports as needed. Lastly, maturity. Older adults will look back on life and feel a sense of fulfillment. Providers can be mindful that this may be a time for the patient to process their relationship with their health and the impact that celiac disease and the gluten-free diet have had on them and their family. Maybe their descendants now have celiac disease or refuse to get tested. Perhaps the individual feels that they may have missed out on some part of their life due to being on a restricted gluten-free diet. Perhaps they are struggling in finding care that will support a gluten-free diet. Providers can help to inquire about the patient's thoughts and feelings about living with celiac disease and make referrals for additional support as needed. We've reviewed Erickson's stages of psychosocial development. We've seen that at each stage, having celiac disease and following a gluten-free diet can have a dramatic impact on the patient's development. This will be helpful in conceptualizing the patient when they present to a medical clinic and office for support from you as a provider. After conceptualizing the patient's experience, we can now consider possible treatment approaches to support the patient. In helping patients with celiac disease, there are two main models of care. One is a psychosocial consultation model where the child and family are seen as part of their medical visit and the mental health provider is part of the medical team. An appointment with a licensed mental health provider in this setting is typically a brief appointment of 15 to 60 minutes and focuses primarily on assessing and intervening to assist with coping with celiac disease and the gluten-free diet. Referrals are given to the patient and family for mental health concerns that are outside of coping with celiac disease and the gluten-free diet. In contrast, outpatient mental health care focuses predominantly on the identified mental health concern and the impact that the mental health concern has on the patient's daily functioning. Sessions typically take place away from the medical setting. Medical concerns can sometimes be overlooked in an outpatient mental health setting due to the focus on the mental health concern and physical distance and separation from medical care. Both settings tend to use two main approaches, motivational interviewing and cognitive behavioral therapy, which we will cover later in this presentation. Now that we know about the two main settings, which one does a patient with celiac disease get referred to? While both approaches have pros and cons, which one is the best fit for a patient? Patients who are adhering to a gluten-free diet with minimal distress or complaints of difficulty in managing the diet, and they've been assessed by a medical professional for possible concerns for adherence, they typically do not need to be seen for further follow-up. Patients who are having difficulty adhering to the gluten-free diet but have no additional concerns about their mood or behavior should be seen in the medical setting for further evaluation and follow-up. Patients who express difficulty with overall mood and behavior, regardless of adherence to the gluten-free diet, should be referred to a mental health provider. For example, let's say that a patient has been referred to you based on this criteria. We'll review the main approaches next. Motivational interviewing is a commonly used technique by both medical and mental health providers to help patients develop the motivation to address the behaviors that are impeding positive change. A full review of this approach is outside the scope of this presentation, but generally, this intervention consists of a conversation between the provider and the patient to help identify the patient's current thoughts around their current conditions. This can be around medical conditions such as celiac disease and following a strict gluten-free diet. Motivational interviewing seeks to motivate the patient to reduce barriers and consider making changes to help themselves. In the case of a patient with celiac disease, this could be a conversation about current gastrointestinal symptoms and perceived barriers to being gluten-free. Motivational interviewing can be helpful in providing motivation not only to adhere to a treatment, but also to seek out additional resources such as therapy. Next, we'll review the most common form of therapy and how it relates to a patient with celiac disease. In addition to motivational interviewing, cognitive behavioral therapy created by Dr. Alan Beck over 40 years ago has been shown to be an empirically based practice that helps patients cope with a variety of medical conditions and psychiatric concerns. An in-depth review of this modality is beyond the scope of this presentation, but it is reviewed here to identify the aspects of the presentation and how they can be helpful to someone with celiac disease. CBT is considered a short-term therapy despite being upwards of 10 months in duration. Unlike motivational interviewing, CBT is a treatment that focuses on problem solving, whereas motivational interviewing focuses on increasing motivation and awareness and is not considered a treatment. The main tenet of CBT is that the meaning that we attribute to events is what causes upsetting feelings. By being aware of our thoughts and making changes to our thoughts and feelings, we can ultimately feel better. This can be useful in helping individuals with celiac disease, as there are many thoughts that are experienced by children, adolescents, and adults. For example, an individual with celiac disease may think they are a burden on others for needing to eat gluten-free. They may think that others do not take their condition seriously, or they may think that they will never be able to eat outside of the home again. This treatment approach can be helpful in identifying these thoughts with the patient and helping to create constructive thought patterns and behaviors that improve their overall feelings.
The process of diagnosis, actual diagnosis, and disease management may be experienced as traumatic. The National Child Traumatic Stress Network suggests taking the following steps to minimize the potential negative effects of disease implication on family functioning. Go back to everyday routines to establish consistency and structure. Be patient with the newly diagnosed individual and with learning how to make environmental changes. Set normal limits. Allow the child to discuss feelings and worries related to his or her diagnosis and change in day-to-day functioning. Encourage time spent with social support. Allow for appropriate independence and decision-making when possible. Encourage caregivers to discuss their feelings separate from the child and to follow up with the child's care team. As previously stated, celiac disease may be experienced as a medical trauma. Medical trauma is defined as a set of psychological and physiological responses to medical experiences. In this case, it may be related to the acute diagnostic phase, ongoing treatment, and/or the fear or experience of cross-contamination. It is likely that the child has suffered from gastrointestinal symptoms such as diarrhea, constipation, bloating, reflux, and/or vomiting for some time before diagnosis. This can involve multiple doctor visits without a clear diagnosis. Once testing has been initiated, it is likely to include blood draws and small intestinal biopsy. In addition, there may be depression, anxiety, moodiness, and inability to concentrate, also referred to as brain fog, during the acute diagnostic phase. Ongoing follow-up and adherence to a gluten-free diet, as well as illness associated with lack of adherence or cross-contamination, can also be experienced. It is important to note that a person's experience of trauma is more of a subjective experience than it is objective in nature. Traumatic stress reactions include re-experiencing the event, as in the case of medical procedures and/or lack of adherence or cross-contamination, avoidance of certain situations that might trigger negative feelings associated with the diagnosis, hyperarousal or hypervigilance, to keeping a gluten-free diet, as well as other reactions such as anxiety. Individuals who are more likely to experience medical trauma include those who have had severe early traumatic stress reactions, experienced previous traumatic events, have been diagnosed with prior behavioral or emotional disorders, have experienced more pain, illness, or discomfort, have been separated from their caregivers, lack positive peer support, and/or present with neurodevelopmental disorders such as autism spectrum disorder and may need modified instructions and follow-up. The National Child Traumatic Stress Network recommends that when someone has a chronic illness, that medical providers use the DEF protocol. The D stands for distress, the E stands for emotional support, and the F stands for family distress. Some signs of distress include agitation, crying, excessive worry, and withdrawal. Distress can be assessed using such scales or instruments as the Child Stress Disorder Checklist and the Child PTSD Symptom Scale. Medical professionals can address distress by providing patient-appropriate information about what is happening, the diagnosis, management of the disease, correct misconceptions, and allow the opportunity to ask about worries or fears. The clinician can provide emotional support by encouraging caregivers to spend as much time with the child and to validate concerns. Provide the child with control by allowing him or her to be involved in decision-making around food choices. Provide reassurance about lifestyle changes, and continue to provide age-appropriate information and explanations, including information that can be used with peers. The medical provider should assess the family's level of distress associated with diagnosis and disease management as well as encourage use of coping resources such as support groups and follow up with a psychologist. Now that we have reviewed the ways to conceptualize cases through a systems and developmental lens, as well as the treatment approaches that could be helpful, let's put it all together by reviewing a few case examples. We'll review a few cases now. As we discuss the cases, think about the developmental stage the person is going through and the treatment approach that may be most helpful. We'll specifically review these dimensions in the next slide. For case example number 1, he is a 21-year-old male who was diagnosed with celiac disease at the age of 8 years. He strictly follows the gluten-free diet, and his medical provider has referred him to see you because of the following concerns. He asks everyone who comes to his home to wash their hands as soon as they come through the door. He does not use soaps in public, and he uses his sleeves or Kleenex to touch door handles. He states that he does all of these things because he fears he will come into contact with gluten. Let's start by conceptualizing this patient from a developmental framework. He is currently in the young adulthood stage and may no longer have support in managing the gluten-free diet from his parents like he did when he was younger. He may also be feeling the increased social pressures, which could be an issue as they may involve going out to eat in public and going to more public places. These would be aspects to query in talking with this patient. In initially meeting with this patient, using a motivational interviewing approach may be helpful to start a conversation around his current behavioral concerns and in what ways these concerns impact his daily functioning. Reflecting the thoughts back to him may help him to become more aware of the intensity in which he is following the gluten-free diet and to see in what ways this has impacted his daily life. In considering a cognitive behavioral therapy approach, you could review the thoughts or cognitions surrounding these concerning behaviors. For example, the patient may think he will die if he comes into contact with gluten, which results in his concerning behaviors. This may lead to feelings of distress, isolation, anxiety, and depression due to these thoughts and behaviors. From a medical trauma framework, you should assess his level of distress, discuss the impact of hypervigilance on his social and emotional functioning, and explore past experiences that may be triggering this hypervigilance. An age-appropriate explanation to disease management should be provided. From the previous talks in this course about management of the gluten-free diet, these concerns should be alerting you to the fact that he is being too restrictive and avoidant of possible cross-contact with gluten. This signifies needing further assistance with overall coping, and a referral to a mental health provider is needed. Let's move on to another case.
As we review case example number 2, continue to think about the developmental context and therapeutic approaches that may be helpful. Case example number 2 is a 12-year-old female who was diagnosed with celiac disease and started the gluten-free diet at the age of 3. Her medical provider noted that her serology labs are positive, and the patient acknowledged that she eats gluten. She denies having any symptoms when eating gluten, and so she does not want to be gluten-free. Let's consider her developmental context. She is in the adolescent stage, wherein she is beginning to take more ownership for her management of the gluten-free diet. In discussion with her caregiver, the caregiver confirmed that the patient is often left to make decisions about her food items without caregiver support. This will be important to consider when thinking of treatment approaches. In using motivational interviewing, the provider can facilitate a conversation about the times when the patient is eating gluten, both to identify what the caregiver and child are doing in these instances. The provider can further facilitate the conversation to help the patient identify the results of these actions and reflect back the impact that these choices have. This may help the patient to identify what their current goals and values are and see how not following the gluten-free diet will negatively impact them. Further utilizing a cognitive behavioral therapy approach, problem solving around thoughts and behaviors that lead to eating gluten can be identified. Eliciting support from the caregiver can also help to provide support to reduce the likelihood that the child will eat gluten in the future. Since these concerns are all related to the gluten-free diet, no referral to a mental health provider outside of the medical setting would be needed. Continuing to keep the medical team involved in this patient's care will be key to continue to assess the patient's health as she restarts the gluten-free diet. Now for our last case example.
Case example number 3 is a 2-year-old female who was diagnosed and started the diet 3 months ago. While she is eating gluten-free foods without a problem, her parents expressed a lot of distress about dining out with gluten-free foods present and supporting their child outside of the home. The family has also restricted their activities outside of the home since starting the gluten-free diet. Let's consider the developmental context and treatment approaches. The patient is currently in the early childhood stage, and due to her age and compliance with the diet, the parents are the main target for this intervention. Using motivational interviewing to have a conversation with the parent will be helpful in identifying the current concerns the parents have and how this has impacted the family. The discussion may highlight the concerns for possible cross-contact with gluten and how they no longer do things they used to do as a family. This awareness may help them to participate in further intervention with a cognitive behavioral therapy approach. Cognitive behavioral therapy may be helpful in identifying the various thoughts the parents might have about celiac disease and the gluten-free diet. Perhaps they think that they will be bad parents if their child comes into contact with gluten. The provider can help the parents identify how their thoughts interact with their behaviors, which impacts their feelings. Encouraging the parents to challenge their thoughts and to try new activities outside of the home with their daughter may help to alleviate some of the distress they are experiencing. From a medical trauma framework, we would gauge the parent's degree of distress, provide emotional support through identifying options for returning to normal functioning, and possibilities for connecting with a social support group. Since the distress is related only to celiac disease, a referral to an outpatient mental health provider is not needed. Hopefully, these case examples were helpful in tying together case conceptualization through a developmental lens and possible treatment approaches to helping individuals with celiac disease. Let's now review what was discussed in this presentation.
In this presentation, we reviewed that having celiac disease and being on a strict, lifelong gluten-free diet impacts more than a person's physical health. Individuals with celiac disease and their families may need additional supports to cope with the condition. Support can be provided in both medical and outpatient mental health settings. Conceptualizing a patient through a systems and developmental lens can be helpful in considering what impacts to query for and what treatment approaches to consider. Motivational interviewing and cognitive behavioral therapy and medical trauma-informed care are the main approaches that can be helpful in motivating patients to change, as well as helping them to problem solve to make changes. These approaches can be used in both medical and outpatient mental health settings. Helping to support not only the physical but also the mental health of the patient can lead to better patient satisfaction and an overall higher quality of life.